Oops. Hello, good afternoon. We're about to begin. We're here at last. I'm stretched. Don't go yet. All right, everyone. Let's begin. The speaker for this afternoon is me. If you want to know more, just Google it. Okay. So my topic for this afternoon, as the last presentation, is on ASV and complex sleep apnea. Others call it treatment emergent central sleep apnea. Now, this topic was supposed to be presented by Dr. Castrota, but due to some technical issues, I'll present it, but this is my slide. So the perspective is more on the technical perspective, not on a physician. Oh, what happened? Okay. Thank you. All right. So here are my course objectives. We're here to define complex sleep apnea and change Stokes respiration, recognize the patients, understand the current treatments and effectiveness of each, and describe optimal treatment options for complex sleep apnea, learn patient qualifications, and we'll be comparing two devices. All right, understanding complex sleep apnea or change Stokes respiration. Now, what is change Stokes respiration? Change Stokes respiration is with central sleep apnea. It is a form of periodic breathing commonly observed in patients with heart failure, and in which central apneas alternate with hyperpneas that have a waxing waning pattern of tidal volume. Now, the whole or the bigger umbrella is, of course, sleep disordered breathing, but under the sleep disordered breathing, you have multiple segments. One is obstructive sleep apnea, central sleep apnea, and change Stokes respiration. Under the obstructive component and central, you have the mixed component, but under the central apnea, that's where the complex sleep apnea lies. Okay. And this is important, especially for reimbursement issues and coding. So I know this is, I mentioned coding reimbursement, but it's not applicable here yet. But however, we might have some attendees that are taking the exam, like our PhD exam, and they will require to have the knowledge. All right. Now, the definition for complex sleep apnea is a form of central sleep apnea. So it is a form of central sleep apnea. Unlike mixed apnea, so mixed apnea is looped, or it's grouped into the obstructive component, right? It's not looped into the central apnea. However, complex is looped into the central apnea, okay? And it's exhibited primarily with obstructive or mixed during the diagnostic night, right? So these patients, they do not exhibit immediate central apnea. They could exhibit obstructive first during the diagnostic portion or mixed. And then it's also identified by central apneas or hypopneas emerging when we are treating them with PAP therapy. So it's one of those late effects. Surprise. All right. Here, it's a sample of a PSG diagnostic. So you can see you have obstruction. However, if you look at the bottom, to me, this is a signature. It tells you something. We don't pay much attention to it, but if you look here, how does that look? Very cyclical, right? Cyclical pattern, even though this is an obstructive event supposedly. So, all right. now this is the patient exposed to PAP therapy. And so all of the events became or switched to central. Now, talking about a couple of studies. This one study with 223 adults consecutively referred over 1 month. Diagnostic AHI was 32, right? 32. Central apneas and in REM was only 0.32. In non-REM is 0.77. So it's very negligible. No, this is not a central patient, right? You would assume. And then CPAP study AHI, all of a sudden it was 21. Central was, in REM was 1.9 or 2. And in non-REM, it turned to 20. Pretty weird. And this is a signature of complex sleep apnea. When they're in REM, they get better. Now, conclusion of this study is that complex sleep apnea prevalence is around 15%. So it's not many patients, right? But they exist. And OSA is 84%, central is 0.4. Now, what's the profile? How do they look like? Don't look at me. Actually, I am on ASV. Just a revelation. All right, demographics and clinical findings. There are no distinct predictive features before CPAP. So they're your typical OSA patients, right? They are slightly lower in BMI, not adequately treated with standard PAP treatments, and dramatic improvement during REM sleep, which is the opposite of a real OSA patient, right? In REM sleep, that's when you have more severe events because of even the further loss of muscle tone to include the diaphragm, right? Further prohibited or inhibited. In CompSA, patients are most similar to those with OSA until the application of PAP therapy. So they switch upon the exposure to PAP therapy. All right. Now, predictable PSG features is that these patients, even if you don't see that they have events, they keep waking up. A lot of arousals. Glenn mentioned spontaneous arousals, right? Others might have respiratory or movement arousals, but these patients, spontaneous arousals. And periodic breathing or centrals are induced before flow limitation is eliminated. What does that mean, right? So typically, when you increase pressure, then you eliminate the flow limited breaths, and then you have a nice sinusoidal waveform, right? They're breathing, right? But these types of patients, let's say you have an event still, either it's a RERA, or now we don't really talk much about it's hypopneas, or they have obstruction, and you increase pressure, and you still have some residual events, so you increase, even if it's just 1 centimeter water pressure, they switch to central. So you go back one, right? As mentioned by Glenn, when you have central, what do? You either wait until the patient catches up and eliminates their own central, or you pull back 1 cm H2O. But these patients, they don't get better. They keep going on either central or obstructive. So there's no sweet spot. Increased flow limitation as periodic breathing increases. And bilevel can make centrals worse because you reduce CO2. That's the good thing with bilevel, is that it reduces CO2. Really good for COPD patients, but opposite for complex sleep apnea patients. And there's always incomplete response to O2. So since you have cyclical pattern, there's some studies that added O2 to the patient's therapy. It helped reduce the AHI, but it never completely optimized the therapy. And then the signature is when these patients get into REM, they are sublime, perfect. No events, or not, very minimal. What are the traditional treatment options? Okay, of course, PAP therapy, but residual events always show up. Then you also, we used to avoid pressure toxicity, which is still advised by some of the clinicians, the doctors, and the APP or advanced practice providers. Now, what they do is that if you do the titration and the patient shows complex apnea, so if they go, let's say they go to 11 centimeters of water pressure, then their obstructions are gone, but now they're doing central. So you wait, we wait, nothing happens, no improvements. And then you will have some arousals too, because that is very difficult to control with ASV, with CompSA patients. So you pull back from 11 to 10 centimeters of water pressure, then they're obstructive events. Again, that shows up. So it's very hard. What they do then is they will prescribe that pressure where when the patient might have obstructive events still, but no central. That's the prescription. That's like the pseudo-optimal pressure. But this is what they usually do when they don't like to use or move the patient to ASV, right? Then, of course, there's a inability to eliminate flow limitation without inducing centrals. That's the pressure toxicity. Some will add O2, and then, because that can also minimize hypocapnia. But they used to give the patient on a prescribed prescription to just control any or to reduce the AHI. That's the most important thing. However, when they do that, you have to get the patients back. So it's not an optimal management. It's to fix it now and then you come back and then let's fix it again. Because it's true, some patients will overcome the central component. But the question is when, right? Nobody knows that unless you test the patient or monitor them. Now, most effective treatment is the three-letter word, ASV. All right, what's ASV? Oh, there's actually 3 companies that make this device. One is Philips, BiPAP Auto SV, ResMed's VPAP Adapt, and then there's Lowenstein. They make ASV too. But these are designed to treat OSA, CSA, mixed apneas, and periodic breathing. It's cleared by FDA, and it can fix CSA or pure or idiopathic CSA. Some patients, even if the patient shows up in the sleep study upon diagnostic testing, some will show central, and those are your pure CSA patients. Is it common? No. Glenn, how many have you seen during diagnostics that you see central immediately without any? It's not very common. Maybe some in pediatric population, but in adults, no, it's not common. All right. Very beautiful devices. All right. So now let's talk a little bit about how do these things work, right? So these devices, upon setup, when you start your titration, usually it will start at the lowest EPAP pressure, whether it's 4 or 5, just to open the airway, right? And then you start with a minimum pressure support and a maximum pressure support. So minimum typically 3 or 4, and then maximum at 10, 15, okay? But the most important thing with these devices is leak. Leak is the enemy. Now, how do the devices work? Okay. These devices, they monitor breath to breath. It's a breath to breath analysis. Oh, some devices are monitoring peak flow. The other devices are monitoring minute ventilation, which is your respiratory rate multiplied by your tidal volume in a minute. But it's as if these machines, they have, of course, flow and pressure sensors. they monitor a moving 3-minute window. So as the patient's breathing, they monitor 3 minutes and they average. One average is the minute ventilation, and the other one is averaging the peak flow, or how high the breath is. Okay. So it's always monitoring, not just one epoch, but quite a bit. You're kind of like your Marites neighbors, always monitoring. All right. Then what it does is it monitors the 90% of that minute ventilation. So when you put the patient on ASV, you don't do anything. Yeah. In fact, you don't do much. Many techs are afraid of the ASV, but I think it's better. It's easier. You get to watch Netflix without much interruption, right? Because the first thing you do is you put the patient, as long as the EPAP is good enough that they will not have sleep onset obstructive events, that means the airway is open. Once the upper airway is open, now it's just the lower airway that you need to monitor to see if they're ventilated, right? So the EPAP is really just to open up airway, correct? You don't do anything as long as that is okay. The patient is not constantly waking up, right? If the patient is constantly waking up at the beginning of your titration, then you increase that EPAP a little bit, just a little bit, right? From 4 to 5, if not 5 to 6. But it's not the same as doing titrations on a typical OSA patient. You don't increase every 5 to 10 minutes. No. After you have established the initial EPAP, you wait a minimum of 40 minutes. So 40 minutes, that's at least one episode of your K-pop drama, right? So what the machine is doing then is it calculates the patient minute ventilation or peak flow, okay? And then what happens now is it maintains the minimum pressure support. It's at 3. When you have a pressure support of 3 and your EPAP is at 4, what is your IPAP? 3 plus 4, 7, right? So your IPAP 7 because your EPAP is at 4 and your minimum pressure support is at 3. Then it can go as high as whatever your maximum IPAP pressure is. However, you don't do anything the first 40 minutes. You leave it alone. Let the machine calculate, because what the machine does now is that, okay, this machine is understanding this patient. Okay, this patient is breathing at, let's say, 8 liters per minute. It will calculate 90% of that 8 liters per minute, right? And then it will maintain that. If the patient is able to maintain that at least 90% of their own minute ventilation, the pressure support stays at 3. It will just sit there and wait. Now, as soon as the patient stops breathing, they go under that target 90%, right? As soon as they stop breathing, the tidal volume, minute ventilation, nope, it's dropping quickly. Then that minimum pressure support that you set at 3 will increase on its own. It'll give a breath. A little by little, it will keep increasing. Now, as it keeps increasing that breath, the patient is now breathing with the device, right? Now it's the machine breath. But how fast it responds is the key, because another machine will respond after an apnea, but this other machine will respond within less than a second. So you will not see any apnea. No, 0. So it'll become from patient-triggered breath to machine-triggered breath. You will see it increasing. Once the patient now is breathing with the machine and reaches their 90% target of their minute ventilation, the machine then stays at that pressure support. Let's say that's now at 7. Then when the machine gets a signal that the patient is breathing on their own, it will go back to minimum pressure support. it will allow the patient to breathe on their own again, because they can supply their own 90% minute ventilation. Okay. So it doesn't over breathe for the patient. It's just there. Like when you're running, like, I don't know who runs here. I run. But imagine you're a runner, right? And then you have a pacer, right? You have somebody right behind you. That pacer is not overtaking you. It's right behind you. But if you're starting to fall back, that pacer will push you a little bit. Stay, you're slowing down, keep going. Okay. That's what the ASV does. That's the pacer. It won't overstep, but it will just, no. Don't slow down too much. Stay at your pace. Maintain that pace, maintain that speed. That's what this machine does. Because if the ASV pushes too much pressure, then it will just increase the O2 CO2 swing, which means that it will then push the patient to have so high of an O2 again and lower the CO2. Then it's gonna, the patient then will have another central. It's not gonna help. Okay. We need the CO2 to go back up enough to trigger us to breathe. So this machine will not do that. It will not overventilate. It can. How do you think it can overventilate the patient? If you have a leak. If you have a leak, right? Not leak, you go to the bathroom. No, the leak in the mask. Unintentional leak. When you have an automatic adjusting device and you have leak, the leak triggers the device to increase pressure. Okay, because it's trying to increase the therapeutic pressure on the mask. If your patient is breathing through their mouth, hopefully not their ears, but the device will keep increasing pressure to give that therapeutic device on the nose. So when that patient then closes their mouth, they have so high of a pressure, then that's when it happens. You have so high of a pressure. But these devices are quicker to respond to back down, okay, to back down on pressure compared to just a typical auto PAP device. ASV is very, very dynamic. I can say that from experience because I use one every night. It's like my partner. Now, this is the other algorithm. This is from, the first one was Resmed, this one is Philips. So Philips, it doesn't calculate the minute ventilation. It doesn't calculate how much volume is in each breath. It calculates the peak flow. How high was that breath? Okay. Of course, the bigger the breath, the higher the peak, right? So that's what it monitors. And it monitors that. Then when it understands it, it looks at the patient's 4-minute window. The first one was 3-minute window, looking at minute ventilation. This one is 4-minute window. It's looking at peak flow. Okay, the average of this patient's peak flow is at this. Then it creates a 95% target of that. If this patient drops their peak flow just 5%, right, it will respond and increase pressure support. Very similar, sort of, right? Nope. So the same, excuse me, the same concept goes when the patient now is missing their breath. So they stop breathing. The device will not see a peak flow because there's no breath. Then the device will increase that minimum pressure support higher and higher. If you started your minimum pressure support at 3, it will start to go 4 or 5 or 6, trying to give that patient a breath. Come on, breathe, right? You need to get that peak flow. Okay, so now the patient is breathing on their own. They went into central. Now they're getting machine-triggered breaths. Now it's the machine breathing for them, okay? And once the machine notices that, okay, the patient's breathing on their own again, because it has a flow sensor and pressure sensor. When the patient creates a flow in the mask, that triggers the machine to go back to the minimum pressure support. Very similar, okay? Now, the difference is that you also have an auto ASV or ASV auto. That mode has an auto EPAP adjustment on its own, right? Not just the pressure support, but also the EPAP increases and decreases on its own. But typically, that EPAP adjustment monitors three major things: flow limitation, snoring, and apnea. All right, let's do another clinical study. This study has 14 patients with stable heart failure. So, and with CSA and Cheyne-Stokes. Method is with a PSG, all patients randomized, and they use 4 different treatments: oxygen, CPAP, bilevel ST, and autoset CS. This autoset CS is the old name for ASV. All right, let's see what happens. All right, results is that with ASV, the ASV got the lowest AHI of all different therapies. See, and ASV also had the lowest central apnea index and arousals more than the other therapies. So again, we mentioned complex sleep apnea having a lot of arousals, spontaneous, even if they might not show or exhibit an obvious apnea, they keep on having arousals. And then ASV increased slow wave and REM sleep. So meaning to say higher quality, right? We talked about sleep architecture, sleep efficiency, etc. And then more patients, of course. I like it. There's other features to these devices why it's a bit more comfortable. And one of them is the way the flow is given, right? When you are on a CPAP, is one pressure. When they put you on EPR or flex or soft PAP, whatever they call, when there's a relief, when you exhale, that's kind of like bilevel. When you exhale, it lowers the pressure. But some of these devices, the way the waveform are delivered is not square. Typically, bilevel ventilators, when it gives you a pressure, it goes from EPAP to IPAP and stays there and then back down to EPAP. So it's like breathing like this. Whoever designed that probably were smoking. But anyway, the other pressure delivery is like an ocean wave pattern, or like it looks, the ASV with ResMed, it delivers an easy breathe waveform. So it looks more like a shark's fin, okay? So it's a bit more physiologic, but is it better? No, because some patients like the other feeling better. If you look at it on a tidal volume, how much air is in each breath, the Philips one with the square waveform has a bit more in each breath. So it's a bit more full breath. But that's different from patients to patients. So you can't say one is better than the other, at least with preference. All right. Now, this study has 21 patients with CSA, CSR. AHI is 51 or 52, right? Risk or RAI is 45.5. So the findings with, just look at this, right? From an AHI of 52 on CPAP, it went down to 34. That's pretty good, right? But not that good, okay? Now with NPPV, it's like a bilevel with a backup rate, went down from 52 to 6.2. I would say that's pretty damn good, right? However, on ASV, it went even further. It's like 0.8. So pretty drastic reduction in AHI, especially with the central index. So the data confirms that in patients with CSA/CSR, mixed apneas, and complex sleep apnea, both NPPV and ASV are effective in normalizing breathing and sleep parameters, okay? But ASV does also more effectively because in these types of patients. All right, another example is you have this patient with central, let me see what pressure. Thought this was a CPAP. I don't see anybody see? Oh, it says C flow, but the tech took out the CPAP pressure. Maybe the tech was in REM. All right. Now you see some central. This patient is on PAP, and with ASV, it normalized quickly. But when you do these titrations, it's almost like magic. How many of you have done ASV titrations? It's almost instant. It is instant. Once you have it on, no more central, right? And here we go. Same thing. Normalized pattern. But let me go back. What is the other most important thing here? Is this. Look at the saturation. Look at the saturation. Very important. Look at that versus on an ASV. Notice any stabilization? Pretty stable symmetry, right? Which makes a lot of sense, how patients on ASV can feel better because they're better oxygenated. All right, now this is an example of an almost instant effect from an ASV titration. This is a 5-minute, maybe 10-minute clip. Yeah. So right here, they change the mode. Right here, they changed the mode. They started the ASV. You see a little arousal, right? Change the mode from PAP, CPAP to ASV. Of course, nobody likes to be choked. But then what happens next is almost instantaneous, that they went and have rhythmic breathing pattern, okay? Given that the leak is controlled, but also the saturation, look at the saturation, 99 to 91. Oh, 96 to 90. That's pretty bad. And then all of a sudden, it was lower, but now it's more stable. And as the night progresses, typically it stabilizes. Now, this is another thing. If you're doing ASV titrations, right, and you're waiting, you haven't increased pressure, you did increase pressure, don't wait 5 to 10 minutes, wait minimum 20, 30, 40 minutes. If you see that there's a trend on the saturation, that it slowly goes up, even if it's just an improvement of 1 or 2%, right? But it's improving, don't touch it. Okay, like MC Hammer said, can't touch this. Leave it alone. Leave it alone. ASV titration can be all night. In fact, it is better all night. It's not a good titration or a mode to start halfway through the night. You need a longer period. It's another topic, but it deals with high loop gain. One of the pulmonologists mentioned the high loop gain, but that's another different topic. It involves that. All right. So this is the other algorithm, but honestly, I don't know much about Lowenstein, so I'm not going to further go into this. This is actually Respironics. But the same idea goes is that when the patient is losing peak flow because of the central apnea, the minimum pressure support kicks in, and these things have backup rates. You can put them on auto rate or you do it manually, right? And typically at the beginning of the night, the most important thing when you do an ASV titration is you do not start it if the patient is still very awake. It's annoying, right? When I first started my therapy, right? See, I'm giving you an insight. I should charge more. When I first started my ASV, I started with an APAP machine for a few years, and then I was moved to ASV. But if you're still awake, your tidal volume or your minute ventilation is higher. When you go to sleep, everything drops, right? You drop muscle tone, you drop respiratory rate, you drop minute ventilation. So everything drops, right? So if you start the ASV while the patient is still very awake, it creates a high 90% target or 95% target. So now if the patient is just starting to relax, it will already start to increase pressure because you started with the patient still on a high minute ventilation or high peak flow because they're still awake, right? We lose muscle tone and minute ventilation as soon as we fall asleep because we have less metabolic needs. All right, almost there. Any questions so far? This is the Lowenstein device. They used to be called something else. What was that company called? Weinmann, yeah. Now it's Lowenstein, right? All right, now Lowenstein has a tri-level mode, but they also have ASV. Algorithm-wise, I've never tried it, never used it, can't explain it to you. Anyway, the ASV though had a warning. A few years back, they did a meta study. It involved thousands of, a lot of patients. I forgot if it was 1,300, but it's a big study. It's called SERVE-HF study. And they showed a negative effect on those with low ejection fraction, particularly with less than 45% ejection fraction. It showed mortality increased. So with that said, they put a warning stamp and we stop using ASV unless we have a proof that this patient has had their heart checked and that their ejection fraction is higher than 45%. All right. Now let's summarize. CompSA is a form of CSA. Central events emerge upon exposure to PAP therapy. If you move them to bilevel, makes it worse. Even if you move them to an ST mode, it fixes it, but it doesn't optimize based on clinical evidence, right? No distinct predictive features before CPAP. It doesn't show any signs of central until they are placed on PAP therapy, all right? And then the code's not important. No, it's not important. Any questions so far? Yes, please.
The mask with hole to release CO2 or not hole when you use for ASV.
So mask, the question was which mask to use on ASV. It's, well, there are many clinical evidence that shows nasal mask is best for titration, even at home. And of course, there's debates, right? Full face mask is, they say, for mouth breathers, but there's pros and cons to that also. Because full face mask, you have a strap that can pull the jaw backwards, especially when they're in REM. And that can make the airway smaller, meaning you're gonna have to increase pressure even higher. So once they go home, they have a higher pressure setting. But with ASV, you can use any mask. I use, what do you think I use? For years now, P10. P10, pillows, yeah. Usually pillows are calibrated up to 18 centimeters of water pressure. So you can use it. Make sure that if you use, there's a few things on masks, you know, like some patients do not like that jetting effect. Jetting effect means like that's a higher flow because there's no dead space to buffer the pressure coming in. So you can feel it stronger. When I first used that mask, because I came from full face, nasal, and then I experimented, right? Except for the Fit Life. That thing leaks too much, makes me want to go underwater. But the pillows, I felt like I was punched by Manny Pacquiao. Yes, but I kept using it. The hard part is the mouth opening, right? But eventually you get used to it. I have my techniques on keeping my mouth shut. Some will tape. I have one of my techs in USC, he tapes his mouth. I use a pillow. I hug it When my wife's not around, even if she's around, I still hug my pillow. I put my pillow against my chin. And then I sleep on my side. And that worked, but it's behavioral modification because full face is too big. It's just too big. Except Restman, I think Marcus the F40. It's the smallest one, but mass-wise, as long as you have good humidification, I will always go for nasal first. The nasal first, especially during titration, because they can always switch masks later on. They have to get through the adjustments on getting used to the pressure, right? And the other things, even the heat of the air. You know that? We don't talk about it much, but how hot the air is annoying. If you have it preheated and it's too hot, now you have climate lines and these temperature settings with the hose or the tubing. If you have it too hot, it's uncomfortable. And then when you have it too cold, you start to cough. So just the right amount of relative humidity. And then you have a good seal. That's the most important with ASV, it's a good seal. Yeah. And sometimes the mass is dictated by the patient, right? Bearded people, good luck. Some patients with very fluffy like cheeks, very hard to fit the mask in. It gets pushed out. And those that use dentures, so when you take off the denture, they go like that. No more teeth, right? Hello. Yes. So any masks, just control the leak. Any other questions?
Yes, Glenn, can I have questions?
Online?
Oh, someone else. Okay.
Yeah, I sent a question already, Dr. C.
Oh, Dr. C. Dr. C?
Yes, I'm from Dalat. I'm online attending. And so I sent a question already. It's just very simple. Can you hear me?
Yes, yes.
Yes, yes.
Okay, and so first of all, thank you very much for your excellent presentations. And so in some cases, we have complex sleep apnea, and not due to CPAP. It means it's not due to the high pressure, especially for those with insomnia due to the instability of respiratory driving. And so if it doesn't work with BiPAP ASV, can we use some pharmacological approaches such as with trazodone, acetazolamide to combine with CPAP treatment, even with ASV? Because some study prove it work. Thank you.
Yes, Doc. I think we have patients that mix pharmacotherapy with ASV. Yeah. Thank you, Dr. C, for that comment. What was the question on the chat, please? There was can you pull up the chat?
Yeah.
There. All right. Thank you. In some patients, complex finding might not be due to CPAP, usually high pressure. Oh, hence the use of ASV might not work, especially for those with COMSA unstable. How do you manage it? So
That was him.
yeah.
Yeah.
How do you do trazodone with CPAP or ASV? So when it comes to the medical portion, whether the patient should be placed on pharmacotherapy in conjunction with ASV, that is the physician's call. So it's up to their call. Depends. The physicians will always make a call to minimize the symptoms of the patients, because we can only do a study so often, right? And so the rest of the feedback is gathered from the patients. If the patients say, even if like the other presenters mention it, if you're sick but you're not, you're sick. But if you feel you have apnea and you feel fine, you don't have apnea. So the patient has ultimately is the decision maker. We can provide them the ASV, but if they don't use it, and that's it. But on Khem, you mentioned earlier to wait for minutes if centrals emerge. Let the body adjust to the pressure that centrals may resolve. How long should we wait when doing this while titrating? And how long does the patient usually take to adjust at home when doc prescribes CPAP despite a patient exhibiting centrals but not prescribed with BiPAP or ASV? Yeah, so the advantage now, like one approach for the physicians or the APP, because we don't just have the doctors seeing sleep patients. We have APPs, advanced practitioners, practice practitioners. We have NPs, nurse practitioners, and we have the physician's assistants that also see patients. What they do is they avoid the pressure toxicity. So if they see on titration that the patient had central at 11 centimeters of water pressure, they will use the pressure at 10. Then they'll let the patient go. And then what they'll do is let the patient get used to the therapy, the pressure, etc., and then recall them back for a follow-up study. Before, it's difficult because you have to always get the patient back in and download the data, but now it's not. They can see the patient's usage every day. It's all cloud-based. So they can see the patient's AHI, if it's improving, leak, usage. Yeah, it's even easier now. So as far as waiting, if you are the tech and you see the patients with central, like I mentioned earlier, if you're doing CPAP and then the patient shows central, wait 5-10 minutes, no improvement, pull back. And then do that again. It depends also on the lab. Remember, when we operate a sleep lab, it's under your medical director's license. What your MD says, that's how you practice. Okay, AASM also can recommend, but the MD's license is what prevails. I've had sleep labs where we call hypopneas with 2% DSATs, and it was an AASM accredited lab because the doctor said, nope, I want hypopneas to be counted with 2%. It's done. I hope that helps. But typically, when you see a central patient, you, as the tech, annotate. You have to talk with your doctors, with your notes, because you're there. You can't call them. Midnight, they're probably out in the bar and hanging out. But you can wait. You can try both. You can back up, or you can leave it where they're having centrals and wait 10 minutes. Annotate 10 minutes, pressure of 10, no improvement with central. And then also look, if I were you, look into the duration of the central event. Because if that central event started at, let's say 15 seconds, you waited another 10 minutes, it went down to 11 or 9, that's a sign of improvement. You might not want to touch it. Because again, ASV titration is all night, should be all night. So you'd never rush an ASV titration. Same thing with VAPs. You don't rush it. Any questions? I hope that answered your question. Well, thanks again, Dr. Say and Alden. How about here? Questions? No? They all just want to go. Oh, before I end, Glenn, I appreciate your listening, right? But we also will need your evaluations. You will get your certificates. It's an e-certificate, but we will need you to get the surveys answered. That's part of our package when we turn this whole thing to BRPT. And so you can get your CEUs.
So Khem will create the survey questions and send it to you guys via email. Okay. So once those are completed, I will send your e-certificates. I already have it created. So, and again, this course is approved for 15.5 continuing education credits. Another thing too, just as a FYI, we've decided that next year's NAPS meeting is proposed for Penang, Malaysia. So I think you'll enjoy. It's proposed to be in a resort, in a beach resort. So so I think you'll enjoy it over there.
We'll get our tan. I'll get my bikini ready. Oh, they're not gonna show up. Oh, on that note, the recording will be ready tonight or tomorrow. I already have day one ready. So for those of you who want to review it and those that are online, those who are asleep but online, they'll get to view it. And that will be open for another week, right? June 2nd. After June 2nd, c'est la vie, no more. Okay. Thank you all for coming.
Thank you,
To our
guys.
speakers, our guests, our support. Van, appreciate you.
Yes, thank you.
Our sponsors, DIP,
Rest
Natus, Knox, ResMed, CALAPHARCO,
Yeah.
Golden State, we appreciate you. And those that are also virtually supporting NAPS, really, really appreciate you. Okay, Glenn,
Yep,
last
that's
words.
it. Course dismissed.
Course dismissed. Thank you so much. Thank you, Vietnam. Picture time.